Good day. Today we're going to talk about high-frequency oscillatory ventilation and the initial settings for patients in ARDS. Much of the information that you'll hear today is covered in a study from 2007 in critical care medicine that's entitled A Protocol for High-Frequency Oscillatory Ventilation in Adults, Results from a Roundtable Discussion. We are going to cover initial settings and adjustments for acid-base status, changes in pH and CO2, how they affect your settings, as well as oxygenation management. However, before you begin, you need to ensure that you have met the indications for high-frequency ventilation. The indications are oxygenation failure, which is defined by an FiO2 of greater than or equal to 0.7, and a positive end expiratory pressure of greater than 14 centimeters of water pressure, or by ventilation failure, which is defined by a pH of less than 7.25 with an initial tidal volume of greater than or equal to 6 mL per kg predicted body weight and a plateau airway pressure of greater than or equal to 30 centimeters of water pressure. It is also important to consider the contraindications for high-frequency ventilation. These include known severe airflow obstruction and intracranial hypertension. Once you deem a patient appropriate for high-frequency ventilation, you must be able to set up the initial settings. To begin, you'll want to set a bias flow of 40 liters per minute. Once this is set, you want to set your I time of 33%, which will avoid a 1-to-1 IE ratio. You'll also want to start with a mean airway pressure of 34 centimeters of water pressure and an FiO2 of 1.0. Again, many of these initial settings came from a roundtable discussion between several prominent members of the respiratory care community and physician community who are very familiar and have done extensive research on high-frequency ventilation. Once you have set your FiO2, mean airway pressure, I time, and bias flow, you want to set an amplitude, or delta P, of 90. This is achieved by adjusting your power setting. Increasing your power will increase your delta P, and vice versa. Once you have set your amplitude, you'll want to adjust your initial frequency based on recent arterial blood gases. For this, you'll want to look at the patient's pH. If their pH is less than 7.10, you'll want to start at a Hertz of 4. For a pH of 7.10 to 7.19, you'll want to start at a Hertz of 5. For a pH of 7.20 to 7.35, you'll want to start at a Hertz of 6. And for a pH of greater than 7.35 on an initial blood gas, you'll want to start at a Hertz of 7. Once you have made these adjustments, you'll want to perform an initial recruitment maneuver. This will help maximize the lung expansion and recruitment of atelectatic alveoli in a patient with ARDS. Before beginning your initial recruitment maneuver, you'll want to ensure that your patient has adequate vascular volume. This means looking at the patient's fluid status and ensuring that they have received enough fluid volume for their heart to support the increase in intrathoracic pressure as a result of a recruitment maneuver. To begin a recruitment maneuver, you need to set your high mean airway pressure alarm to 55 centimeters of water pressure. You'll also want to turn off the piston, which is done by depressing the start-stop button on the oscillator. You will then raise your mean airway pressure to 45 centimeters of water pressure via the knob on the right next to the bias flow. You'll want to achieve this mean airway pressure of 45 over a 10-second period. You'll then maintain 45 centimeters of water pressure for 45 seconds. After 45 seconds, you need to reduce your mean airway pressure back to your initial setting of 34 and reset your high mean airway pressure alarm to 40 centimeters of water pressure. You will then turn the piston back on, reset your delta P to 90 centimeters of water pressure, and observe the patient for 10 minutes. As you perform your recruitment maneuver, you will turn the knob clockwise to increase your mean area pressure, and then counterclockwise to decrease it. It is always important to remember that adjusting this knob should be done in slight increments, as extreme changes in the knob position can cause extreme changes in your mean area pressure, which could result in a loss of recruitment on a patient. After doing your initial recruitment maneuver, you want to determine if your oxygenation is within the goal range, and this will be determined by your SpO2. If your oxygenation is not within your goal range, you can repeat the recruitment maneuver, but you'll need to raise the mean area pressure to 50 centimeters of water pressure and then reduce it to 36, again over a 45-second period. If your oxygenation is greater than your goal range, you can decrease your FiO2 by 5% every 5 minutes until your SpO2 is between 88 and 95%. Once your recruitment maneuver has been completed and you've returned your patient to your initial settings, you'll need to observe the patient for 4 hours and increase the FiO2 as necessary during this period to achieve your oxygenation of less than your goal range, persisting for greater than 5 minutes. If after 4 hours your oxygenation is greater than your goal range, you can decrease your FiO2 or your mean area pressure every 2 hours. Typically, this is done by decreasing your FiO2 by 5 to 10%, or by decreasing your mean area pressure by 2 centimeters of water pressure. However, if your oxygenation is less than your goal range, you can increase your FiO2 or your mean area pressure every 5 minutes, again, increasing your FiO2 by 5 to 10%, or increasing your mean area pressure by 2 centimeters of water pressure. Referring back to recruitment maneuvers, if a patient becomes disconnected from the oscillator for any length of time, it is a good idea to perform a recruitment maneuver immediately after hooking the patient back up. For oxygenation management in a patient with ARDS on the high-frequency oscillatory ventilator, you have two main controls. You have your FiO2 and you have your mean area pressure. The FiO2 is mainly adjusted by your oxygen blender, which is found on the lower portion of the oscillator, but is also adjusted and affected by your mean area pressure, again with the knob to the right. Increasing clockwise will increase your mean area pressure and vice versa. It is also important to remember that in order to monitor the FiO2, you will need an oxygen analyzer in line with the circuit and the flow meter that is attached to the blender. It is important to remember that while the oscillator is more for oxygenation, there is also a ventilation component that must be adjusted. The main control for adjusting ventilation on the oscillator is your frequency. This will control both your rate and your tidal volume. Again, remembering that the higher the rate or the frequency equals a lower tidal volume. This is a result of the change in piston speed and distance within the housing. Higher frequencies mean that piston drives a shorter distance and vice versa. When managing ventilation on an adult patient on the oscillator, it is important to remember that your Hertz is your primary control for your ventilation. Your Hertz controls your tidal volume and your respiratory rate. The higher your Hertz, the higher your rate, and the lower your tidal volume. This is important to remember when you're drawing blood gases and adjusting for the patient's pH. Again, the higher the pH, the higher the Hertz you want in order to achieve a smaller tidal volume and allow for more permissive hypercapnia. When trying to affect a change in your acid-base status by either decreasing or increasing your pH, a secondary control for ventilation is your power, or delta P. The power is the setting that controls your change in pressure. As you increase your power, you'll increase your delta P, which can increase your ventilation, and of course vice versa. The lower your power, the increase in CO2 will occur. Today we have covered the initial management and initial settings for a patient on high-frequency ventilation. For long-term management, there are several resources available. You can refer to the Respiratory Therapy and Pulmonary Diagnostics website, but more importantly, you can refer to the Critical Care Medicine study from 2007 that covers protocol for high-frequency ventilation in adults. It is volume 35, issue number 7, and can be found through a quick Google search. This concludes today's presentation on initial settings and management of a patient in ARDS on high frequency ventilation. Thank you.